So this patient, unfortunately, another young patient who is drinking a lot, and they were in their 30s, I think. And you can see he's got a lot of anasarca by the time we see him. But sorry, I'm trying to get okay. So you can see his liver is got a lot of steatosis in it, and we have ascites, and we have a tip shunt that they placed. And one of the reasons that they placed the tip shunt was he was going into liver failure, but there was also a portal vein thrombosis. And you can see that there is an Amplatzer plug in the spleen here. So this is similar to a prior case I showed where they did a transplenic TIPS. So they went through the spleen into the splenic vein. This is a way to do a TIPS if your portal vein is thrombosed. It was basically described at Northwestern a few years ago. And so they're using it more and more now for patients who have portal vein thrombosis where you need to recanalize the portal vein, or if you need to do a TIPS in the setting of a portal vein thrombosis. And at Northwestern, they had about 50 patients they did, and only 3 of them failed and kind of rethrombosed. So they described this procedure and said it was pretty safe. So we've been doing it quite a bit at Emory. And as they leave the spleen, they put a big sheath in the spleen, they put this Amplatzer plug in. In this patient, unfortunately, he was very coagulopathic because of his severe liver failure. And so his spleen was actively extravasating out of that hole that they had put in the spleen there. You can see that there's a lot of ascites, and some of it was hyperdense. You can see all this hyperdense hematoma in the pelvis. And then the patient, we don't want to have satisfactory search, which is what we did initially with this case. The patient also was actively extravasating in their abdominal wall here from a branch of the inferior epigastric artery that was from a paracentesis. So they had 2 areas of active extravasation. So I was actually just telling my residents recently, like, oh, I'm getting less concerned about biopsying the spleen, given that our IR colleagues are constantly now going transplenic with these big sheets. And then this case came up, and we decided, we're not going to get too cavalier with biopsying the spleen. But anyway, so this was just an example of doing a transplenic tip shunt, unfortunately. Especially the patients we have that bleed the most are these ones that are in fulminant liver failure. So their clotting factors aren't working. And you could see that even, he's now bleeding actively from multiple sites. So probably it isn't a technical failure. It's that, they were going to bleed from wherever we intervened. Unfortunately, this patient actually passed away the next day.
Can you guys hear me?
Yep.
When the liver disease patients get into problems of coagulopathy, it can be so severe that that's basically the reason, like in this case, they don't survive. We had a case recently, it was shown at a AM or something like that, where there was a hemorrhage. It was in the patient had a endoscopy, and subsequent to the endoscopy, there was some bleeding in the area of the cecum. It wasn't intraluminal, it was actually on the surface of the valve, and it was caught kind of late with hemoperitoneum, and our IR people got in there and tried to slow down the hemorrhage, but it wasn't successful.
Yeah, and actually this is what all of these coils here are from the BRTO. So we did try to go and coil all these varices going to the gastric fundus that were bleeding, and that's why he got the tips, because he was having a lot of GI bleeding, and that, yeah, those coils also weren't effective enough. So that's it. Does anyone else have cases?
I did not have time for cases.
We have a couple cases.
Okay, I've stopped sharing.